Greetings to one and all. I'm here to present a lecture on topic called scabies. My name is Dr. Giordani. I'm an assistant professor of dermatology in Sree Balaji Medical College and Hospital. Today's topic, we'll be covering some of the presentations in which scabies infestation can come, and the life cycle of the scabies mite, which is responsible for causing the infestation, and also the various variants in which it can present clinically. We'll also have a detailed engagement on the diagnosis and management of this commonly encountered condition. So now scabies. So what is scabies? Scabies is a infestation. Sometimes we use the misnomer infection, scabies infection sometimes, but it is an infestation. It's caused by a parasite. So this parasite is Sarcoptes scabiei var hominis. There are many animal variants as well, but Sarcoptes scabiei var hominis is what infects humans most commonly. So this infestation is caused by this mite, which is dependent on the human for life cycle. It can barely live for maybe around 72 hours outside the human host. So the entire life cycle of this mite is restricted to the epidermis. Rarely it can invade into the dermis, which will present a melange of many other complications which we'll look into later. So some of the synonyms for this condition include Bonomo's itch, the 7-year itch, pruritic eruption, and also infectious eczema. Right. So moving on to the epidemiology of scabies, the incidence and prevalence of this condition, it affects around 100 to 300 million people worldwide. It's very commonly seen in developing countries and third world nations as well. The prevalence varies considerably, with some of the underdeveloped countries having rates ranging from 4% to 100% of the general population. It continues to be an endemic disease in many societies, including in our country. It is transmitted by close physical contact. So age and sex ratio, it can affect people of all ages and all sexes. There is no predilection usually. However, it becomes more frequent in the elderly, in residential and nursing home environments, and also in places like prisons, de-addiction centers, etc. The overall sex incidence, as earlier said, probably equal. Now looking into the mite itself, the mite belongs to the order Acarina, the class Arachnida, and the family Sarcopteae. So Sarcoptes scabiei var hominis, there is variation between the male and the female mite. The female mite has 2 pairs of legs at the rear end with long bristles termed as setae. In the male, the bristles are present on the 3rd pair, and the peduncles with the suckers are present on the 4th pair of legs. Looking at its life cycle, so the adult female, after invading the human host, starts to burrow in the stratum corneum of the host. Then it starts laying its eggs and scibala, which is its fecal material. Now the eggs start hatching over the course of 2 to 3 days to form larvae. These larvae, over the course of 3 to 4 days, molt and form the nymph. The nymph then evolves into the adult over the course of 4 to 7 days. And the adult female or male again goes through the same cycle over the course of a period of 2 to 3 months usually. So moving on to the clinical presentations that we commonly see, the classical variant of scabies, which is seen in most individuals, they mainly complain presenting with nocturnal itching and a family history of similar nocturnal itching, and also there is a typical lesion called the burrow with a characteristic distribution over areas termed as the circle of hebra. The onset of infection is usually after 3 to 4 weeks. The intense pruritus usually spares the face in adult classical scabies, hence necessitating treatment only over the face only in the pediatric age group less than 12 years of age. Nocturnal itching is usually due to the low cortisol levels that we normally see in the evenings. The cutaneous lesions usually tend to be symmetrically distributed, Commonly, there are small erythematous papules associated with variable number of excoriations seen. So now the other clinical variants apart from the classical variant include scabies incognito, where application of topical or systemic corticosteroids would have ameliorated the symptoms or signs of scabies. They bring down the inflammation and also bring down the pruritus associated with scabies, and hence patients with this variant might not present with the classical nocturnal itching symptoms, and it requires a high degree of suspicion from the clinician to diagnosis. So scabies and clean. So the lesions may be sparse and present with itching. So scabies and clean refers to those who, despite proper hygienic practices, acquire the infestation through close contacts of those who have been affected with classical scabies. This scabies and clean may also occur sometimes in those who are taking care of old debilitated individuals, such as caretakers in hospitals, nurses, and also caretakers in various alcohol and drug de-addiction centers. Now, scabies in the bedridden, this is limited to sites in contact, close, constant contact with the sheets. This is invariably seen in old, elderly persons and also in persons with degrees of quadriplegia, hemiplegia, etc. So, the pathognomonic lesion is called a burrow. It is also termed as a jetliner trail due to the characteristic appearance of this lesion, which you can see in the picture. It is a thin, thread like linear structure ranging from 1 to 10 micrometer in its length. The tunnel is formed by the movement of the mite in the stratum corneum. The mite has various enzymes in its saliva which tend to digest the keratin in the stratum corneum, and thereby it forms a tunneling burrow for it to move around and lay its eggs and scabala in. It is best seen in the interdistal web spaces and over the volar aspect of the wrists. So, this is the circle of hebra we were discussing about, described by the renowned Austrian physician von Hebra. So, circle of hebra constitutes, starting from the interdistal web spaces, it goes on to the anterior aspect of the wrist, and then to the ulnar aspect of the forearm, and then the cubital fossa and the elbow, and then it involves the axillae. From then, you can trace the circle onto the periumbilical region in the gluteal area and over the genitalia and the thighs. So, an atypical presentation of scabies is seen in infants and in young children because facial involvement is more common in them. The mite usually cannot enter the facial region in adults due to the increased sebum production noted in adult skin. So, the involvement of the scalp, neck, and even the palms and soles, owing to the lack of the stratum lucidum layer in the palms and soles in these younger individuals, may occur. So, animal scabies. So, this is not caused usually by the scabies mite, which causes the infestation in humans, which is Sarcoptes scabiei var hominis. Parasites belonging to the same Sarcoptes family affecting dogs and cats, such as Sarcoptes scabiei canis, etc. They cause scabies. The eruption here tends to be even more remarkable and violent. Patient presents with more remarkable symptoms and higher degree of inflammation, but it is a self-limiting condition as this mite does not have any life cycle in the human host. So the domestic animals that may become infested with this animal's form of scabies include swine, cattle, horses, sheep, goats, and dogs. With frequent close contact, rarely these kinds of animal scabies instances can occur in humans. So nodular scabies. Now this is denoting a type 4 hypersensitivity reaction. So there you see many persistent reddish brown pruritic nodules distributed all over the body in younger individuals. Commonly in older individuals, we tend to see these lesions near the genitalia, over the scrotum, and over the intertriginous areas. These nodules do not contain the mite itself, but they are only a hypersensitive sensitivity eruption to the contents of the scibala or the eggs or the mite's body itself. So Norwegian scabies, this is very important clinical presentation of scabies, also known as crusted scabies. So this is an abnormal host response to the organism. So you see multiple thickened plaques over the regions normally where you will notice the papules of scabies. You see multiple scaly thickening of the skin, forming crusts in these individuals. It is usually seen in individuals who are senile and elderly, those with mental challenges, those with intellectual disability like in Down syndrome, patients with poor cutaneous sensation owing to various neuropathies and palsies, and also those with severe systemic diseases, and also in immunosuppressed patients, including those who are on long term chemotherapeutics. So, this form of crusted scabies, the theories that we are postulating for the development of this is owing to the uh, reduced itch scratch cycle in many of these patients because of owing to the various causes, neuropathy or their intellectual disabilities. They do not tend to itch, or the itch response is very minuscule in these patients. So they do not tend to itch and scratch and bring the counts of the mite down. So it is not uncommon to see lakhs of mites in these patients, whereas in a normal individual, at any given time with classical scabies, you generally tend to see around 12 to 13 mites. So diagnosis. So the diagnosis of scabies is usually clinical. Microscopic examination of the burrow will reveal mites, eggs, fragments of its eggshells, or scabala. A skin biopsy is rarely needed, and if done, sometimes might show thickening of the epidermis and also a variable inflammatory infiltrate composed of neutrophils or eosinophils. Coming to the complications of scabies, so scabies can induce insomnia, secondary impetiginization can occur, heat eruptions can occur, and also post streptococcal glomerulonephritis can occur due to secondary infection by Streptococcus pyogenes. It can rarely even cause urticaria, and also rarely the crusted form of scabies can end up with erythroderma. Now, management. So, the treatment should be prescribed to the patient and also all close physical contacts, even for those without any pruritus or cutaneous lesions. As earlier told, the infestation may take around 3 to 4 weeks to manifest after the mite has lodged itself in the host. Patient education is very important. Detailed information should be given about the nature of the infestation and the need for therapy of the close contacts. Patients should be advised to avoid close physical contact until they and their household members have been treated, preferably simultaneously, so as to break the chain of transmission. So now coming to the therapy. So the therapy in scabies is usually centered around agents which target the nervous system of the mite. So permethrin is pretty much the most widely used drug in the treatment of scabies right now. It is derived from the plant chrysanthemum. So permethrin cream, 5 percentage strength, is used topically overnight on day 1 and on day 8. A week's interval is given so that as permethrin does not have any effect on the eggs, any larva that may hatch out from the eggs over the course of the next 7 days may also be killed by the repeat application. Risk factors: any allergy to formaldehyde, which is an important component in this formulation, can be a deterrent to the usage of permethrin. Efficacy is good, but nowadays we have been noticing some amount of tolerance. And permethrin is also being used with caution in pregnant patients nowadays. Lindane lotion at a strength of 1%. So, gamma benzene hexachloride, also known as lindane, is another nerve agent. It is used topically, repeated again after 1 week, overnight application followed by 7 days. So, this is similar to permethrin in its usage. The risk factors, however, include CNS side effects. Hence, especially when you are applying in the skin of infants and children where the absorption is much higher, this can lead to seizures in the children itself. So its usage is being restricted of late now, and it cannot be used in pregnancy. The efficacy is also coming down nowadays, and resistance is quite common. So sulfur 5% is a time-tested molecule and one of the oldest molecules used in the treatment of scabies. It needs to be used topically for 3 nights continuously. There are no risk factors with sulfur except for its small odor. Efficacy, however, is variable, and also it tends to have a tendency to cause some amount of irritation, especially when applied in the intertriginous areas. Benzyl benzoate at a strength of 12.5 to 25 percentage can be used topically 3 times in 24 hours. Again, this cannot be used during pregnancy and also in infants less than 2 years of age. So this may be considered in permethrin resistant cases, as the resistance still tends to be low, as benzyl benzoate was never widely employed in the treatment of scabies so far. So newer molecule crotamidone 10%, it is used topically overnight on days 1, 2 and 8. There are no risk factors, however, its efficacy tends to be very poor, but now it has got a renewed usage for its antipruritic effects in the post-scabetic itch, where the itchy lesions persist due to the hypersensitivity to the mite, and protometon has a great tendency to bring this itching down. Ivermectin, used at a dose of 250 to 400 microgram per kg body weight, it is used usually on days 1 and 8. Again, a 1 week interval is given, as even ivermectin, similar to permethrin, does not have any effect on the unhatched eggs of the mite. So avoid if the patient is less than 15 kgs, and it should be avoided in pregnant individuals as well. There is some amount of discussion and debate whether it can be given in those with a tendency for seizures, as there have been isolated anecdotal events where it can trigger seizures in individuals. The efficacy is excellent, with almost 100% clearance noted with the oral formulation of the drug. Now, also topical formulations are being brought in, available as lotions and creams. So, ivermectin tends to target the chloride channels of the mite, and it brings about a respiratory arrest, respiratory failure in the mite, by paralyzing its respiratory muscles. Now, the recent advances in management, moxidectin is being used in the few cases of resistance that we see in ivermectin, and spinosad is another promising molecule being employed for topical therapy in scabies. So, to conclude, scabies is an infestation that affects humans and spreads by close contacts, and is usually seen in places where there's a lot of overcrowding, poor hygiene, and also in poor socioeconomic status individuals due to housing conditions, etc. So this is an infestation that easily spreads from one person to another. It should be borne in mind that whenever we treat scabies cases, to treat the contacts. This is very important, as the mite can reside in another host innocuously without causing much symptoms. So it's very important to treat the close contacts of the person who is affected with scabies. So the condition is usually diagnosed clinically, as stated earlier, and we don't have any specific lab investigations, or it does not necessitate anything invasive like a skin biopsy or such. So we always have a high degree of clinical suspicion whenever the patient presents with this complaints of nocturnal itching, and also these multiple papillary lesions and burrows involving the circle of hebra. And management, as it goes, we use a lot of various anti-mite agents. So mainly drugs that target the nervous system of the mite, like your organophosphorus compounds like malathion, then also drugs like ivermectin, permethrin, etc. So scabies is easily treatable, and sharp clinical acumen is required by the doctor to probe the patient's history and elicit the necessary details to come to the clinical diagnosis. Thank you.